All right, thanks. Is there a role for pedal arch reconstruction in today's CLI world? So, you know, there's not a lot of data. You can imagine how tough CLI trials are. Imagine doing one for pedal arch. So I like to say it makes sense, right? Last delivery mile challenge. I mean, if your Amazon boxes get to the local post office but not to your door, it's a problem. So, Fadi showed some small amount of data this morning with the meta-analysis suggesting that below ankle intervention had better outcomes. This is an example of one of those studies out of Japan showing that if you did pedal artery angioplasty, you had improved wound healing. So really, I think it's more of the ultimate expression of the angiosome concept. I think if we can get direct flow to the wound, it's always better. Now, I'll tell you that it is getting, I think, tougher because, with diabetes, chronic kidney disease, and aging population, we just see higher MAC scores and higher SAD scores. So, DVA luckily is around and has become a really good option. You want to find an artery that's more like on the right side. When I talk to a patient and think about pedal arch reconstruction, I'm a lot more hopeful if I see the ultrasound prior that looks like the right side as opposed to something that you would see on the left. So again, this is borrowed from Stephen's talk, but when we do TAD-V, limb flow, there is potentially a shunting, a steal phenomenon. And so I think that it's still important to be able to do sort of conventional revascularization because you remember the TAD-V doesn't really kick in and mature for several weeks. And so really what's important is to keep that foot as stable as possible, not compromising the existing blood flow, which is marginal at best already. And so sometimes it's important to try to optimize that revascularization as much as possible prior to TAD-V. So I'm going to be more of a technical talk, and this is a little bit of a continuation of this morning's tibial intervention talk, but really what you need to know is the anatomy, okay, and be familiar with the anomalies. All the techniques that we use in the SFA, POP, and tibials like I showed you today also can be carried out in the foot. Ultrasound guidance, so again, knowing distal access, so digital access, for example, can really bail you out in situations where the pedal arch reconstruction is not going the way it should. High quality angiography. So we just talked a little bit about, antegrade access, taking pictures from the popliteal position, but I'll show you even more selective injection sometimes is necessary. So again, this is just for, informational purposes. Take the right shots, not just a straight AP. Try to take the time to really set up the foot and so you can see how the pedal arch travels. Different anomalies. And like I said, it's important to know that these exist because when you're working on it, it's because it's not there that you're working on it. So here's an example on the left of a shot from the popliteal artery showing what looks like an occluded dorsalis pedis and lateral plantar artery. But when you get down a little closer with an 014 or 18 support catheter and inject in the dorsalis pedis itself, you can actually see that it is open, but just severely diseased. So this is the exact same patient, and you can see that when I get into the lateral plantar artery and I inject and the dorsalis pedis artery, from the different views, I start putting together the puzzles of this plantar arch. So here you can see I have a CXC catheter really deep in the loop, within the loop. And so I inject through that and I get more pictures of the puzzle. I see where my wire goes and, doing it a lot, you kind of can put it together in your mind. But here's what the pedal arch looks like in this patient. And so that's what we did with with the multiple selective injections. And you can see the before and after. So again, these are wires that I've used. This has not changed in 10 years, and I probably should, get with the side people and try some of the newer wires. I'm sure they're excellent. But I was just talking to them. I was like, I don't think I've changed a slide in 10 years. Maybe 5. The Fielder XT, I think, is a really special wire. If you have an arch that is relatively open but difficult to navigate, this is that wire has a 009 tip, and what's really important is to put a really sharp bend at the tip, because if you don't put the bend close enough to the tip, in a small artery, you basically have a straight wire. You can't navigate anymore, okay? So this wire is nice because you can really, I put it through the introducer, and I use the introducer to just fold it down and get a bend at the very tip. And it maintains directionality even in the smallest arteries in the arch. So we talked about some of this. So here's an example of a diabetic who had, pretty open tibials and just really bad foot disease. And so again, knowing where the arteries should be running and what pieces of the puzzle that you can see. And again, if you notice, staying on, DSA, 4 frames per second minimum. Staying on the pedal to watch the collaterals fill gives you more pieces of the puzzle. So here's a looped wire technique, with a CXI catheter pushing forward to the wire and catheter from the contralateral tibial. Here's an example of a cart or reverse cart technique. So, I have a balloon from one direction with 2 wires, and, Anyway, after I ballooned, I was able to get into the other tibial artery, and you can see we treated that patient, and this is what the arch looked like afterwards. Ultrasound, again, I don't do it as much as I used to, but external ultrasound can really help you when you're looking at these arteries, both in terms of success, predicting success, but also navigation. Here's an example of a woman that had this sort of very localized ulcer that wouldn't heal and had a occluded dorsalis pedis. So here, what you're looking at is the dorsal metatarsal artery, and you see my wire is subintimal. It's just, in the wall of the artery at the calcium. So we did a dorsal metatarsal stick and fed the wire up. You can see the wire, it looks like it's going right into my support catheter from above, but it's not, it's subintimal. So we did a balloon cart technique here, and then was able to cross from the dorsal metatarsal artery into the anterior tibial artery, and balloon angioplasted that and treated that successfully. Thank you.